Don't let anyone tell you there are things we cannot change. We've done hard things before. We'll face hard things again, but we're doing it. Thousands of people will live simply because a whole bunch of people in here keep making medicine better. So if anyone ever tells you there's no other way, don't listen. We find a way. Mount Sinai.
Good afternoon, everybody, and welcome to this exciting panel event. My name is Joe Borello. I'm a PhD student here at Mount Sinai, a prototyping fellow in Sinai Biodesign, and one of the organizers of the Thrive Fellowship Program. And so this is a super unique event we're doing, open not only to our Thrive fellows, but to the wider Mount Sinai community. And so very quickly, by way of background, I'd like to quickly introduce the program for those who might not be familiar with it. We started this last year in response to the COVID pandemic and the kind of disruption of normal innovation activities at Mount Sinai. We pivoted away from our normal hackathon that we hold every fall and spun it into this program, which brings together multidisciplinary teams to work on team science and healthcare innovation projects. So last year, obviously, we focused a lot on the COVID pandemic. This year, we're focusing on surgical innovation. So briefly, Thrive is a 9-month fellowship offered in collaboration between Biodesign, Conduits, and MSIP. And the whole idea is to expose a diverse set of trainees from the health system to all of the different opportunities in healthcare innovation, help them form teams, and then help them build products that will ideally see use in the clinic and in the real world. We're here to kind of bring together the network of Mount Sinai in a cohesive way and help guide people through it so that they can get the most out of the opportunities offered here. As I mentioned, surgical innovation is the overarching theme for this year's program, and we've kind of split it into 3 verticals. Our Thrive Fellows just finished going through implants, imaging, and surgical robotics, and we're now kicking off the health equity in the operating room vertical with this panel event. And so this is looking not only on the things that are happening in the OR itself, and the decisions that go into that, but how social determinants of health and disparities in healthcare affect the whole continuum of care for patients. And so we're very excited to have this great panel of speakers here today to talk about this, and I will give them quick introductions, and then we'll get into it and let them introduce themselves as well. But first, we've got Susan Khalil, who is the Director of Minimally Invasive Gynecologic Surgery at Mount Sinai West. She has an interest in robotic surgery and experience in a whole variety of clinical care settings. And also has a strong interest in improving patient safety and commitment to helping patients and their wellness. Next up, we have Dr. Rajwan Thelaswamy. He is an assistant professor of medicine here in hematology and medical oncology, a board-certified medical oncologist who specializes in the treatment of lung cancer and other thoracic malignancies. And his research focuses on understanding the factors responsible for clinical outcomes in lung cancer patients, from differences in care to therapeutic drug efficacy. Next up, Nina Bikel. Dr. Nina Bikel is a senior leader at the Tisch Cancer Institute and is affiliated with so many programs. I can't list them all, but I think most importantly to what we're talking about today, she is a co-leader of the Cancer Prevention and Control Program and a co-director of the Center for Health Equity and Community Engaged Research. Dr. Bikel conducts research on assessing causes of and creating interventions to reduce racial and ethnic disparities in cancer care. And last but not least, we have Daniel Ranty, a current student, actually an MD student here at Mount Sinai, interested in pursuing a career in urologic oncology. He is also the spotlight lead for the Diversity Innovation Hub, which is the DIH's initiative to showcase researchers, clinicians, and entrepreneurs from the Sinai community and beyond, working to advance diversity, equity, and inclusion in medicine. And so with that, I would again like to welcome all of our panelists. It's great to have you here, and I will kick off this discussion with essentially letting you kind of give more background on yourselves. And so, a quick introduction, background, and some of the current things you're working on at Mount Sinai. And we'll start with Dr. Khalil.
Hi, thank you very much for having me today. I'm in the Division of Minimally Invasive Gynecologic Surgery. I'm site director for minimally invasive GYN surgery over at Mount Sinai West, and APD for the fellowship in minimally invasive GYN surgery at Mount Sinai Hospital. I also play an active role in quality and patient safety within our department, and I'm very honored to be here today and talk about a topic that's very dear to me. So I welcome all questions and a good dialogue today.
Great, thank you so much. Dr. Velaswamy, if you want to elaborate a little bit on background and work.
Sure, happy to be here. I'm Raj Velaswamy. I'm a practicing thoracic medical oncologist and a clinical and translational researcher. A lot of my research is really focused on comparative effectiveness of various lung cancer treatments, so including surgery, and with the focus in understudied populations. So outside of clinical trials, but more recently I've kind of transitioned a little bit on really trying to understand the biology that's underlying the differences and the outcomes that we see with various clinical phenotypes. Yeah, so looking forward to the discussion.
Great, thank you very much. Dr. Bikel, if you want to give a little more background.
Sure. Hi, I am a primary care physician and a health services researcher. And most of my work has focused on basically understanding reasons for the differences that we see in outcomes of BIPOC populations, so Black and Indigenous people of color, and coming up with interventions to really try and address and redress the inequities that we see, because they really have been, and unless we do more, will continue to be quite striking and quite egregious, I think. Do you want more than that, or is that?
That's a great opener, thank you. We'll dive into more of these topics specifically as we go along. And Daniel.
Hey, everybody. Thanks so much for having me. I'm proud to be the least credentialed person on this panel. I'm currently a fourth-year student in the Portal program. I am an aspiring urologic oncologist. And the bulk of my research and sort of thoughts over the last year and a bit have been on immunotherapies and bladder cancer. And in addition to that, I also am one of the organizers for the Spotlight series at the DIH, which sort of organizes for individuals who are inside and outside of the Sinai community to come give presentations on how they are sort of folding in diversity into their sort of like core innovation ideas. So yeah, super happy to be here.
Great, thank you all very much, and we'll jump into some of the first questions here. I'm going to go in reverse for this one, so Daniel, you can kick this off. But social determinants of health is something that kind of sits over all of this and different factors outside of the medicine we might think of traditionally in an academic sense, impacting clinical outcomes. And so for each of you, what I'm curious to hear is, how do social determinants of health impact your work? Are there any kind of specific examples that you can share, or other examples you've seen in the course of your career? So Daniel, you can kick this off.
Yeah, definitely. So I think this question I'll talk about from the perspective of bladder cancer treatment, just because that's, I think, the thing that's closest to my work now. So a little bit of background first. Bladder cancer is the most expensive cancer per capita to treat. And I think a lot of that is due to the sort of treatment cycle and the maintenance process that people need to undergo when they get treated for bladder cancer. And it's an incredibly difficult cancer to treat in the process of just like getting people into the hospital and getting them sort of at these massive number of touch points. I think largely because when you're determining whether or not a patient has recurred, the way that they do that is through cystoscopies. And so the treatment process involves, putting something physically into somebody's bladder, and then all the follow-up treatments cost so much money simply because you need to have a board certified urologist to actually look in the bladder. And all this to say is that the treatment for bladder cancer really is going to skew more effective towards people who have the financial means and the financial literacy to pursue those treatments. And so I think that that's one thing that I see, and sort of something that I've noticed, is that sort of the patient populations that we predominantly treat for bladder cancer are patient populations who skew towards, Caucasian men. And beyond simply just the treatment that people receive for bladder cancer, the research that I do is primarily through, it's primarily sort of on the immunologic bases of bladder cancer recurrence. So understanding why patients fail immunotherapies that are sort of first line now. And one of the really interesting things there is that the current consent form that we use really is limited to people who are English speaking. So I think this is sort of a specific example of how we're sort of currently, just due to the resources we have at our disposal to consent patients to getting included in research, we're really sort of excluding a vast majority of people that actually would be sort of transformative in understanding, what are the differences that people have in this disease.
Great, thank you very much, Dr. Brickell. I will toss it to you and get your thoughts on social determinants of health and how it feeds into your work and research and clinical practice.
Yeah, so it feeds into all of my work. And so social determinants are a critical factor in exposure, in risk, in development of illness, in detection of illness, in treatment of illness, and in follow-up and ongoing surveillance. So across the spectrum, particularly in the case of cancer, social determinants impact tremendously. So in terms of the work that I have been doing, and I guess sort of gearing it more towards surgical, because I guess that's what this is focused on, there are a number of ways in which the issues of social determinants have impacted. So early on, we started to look at differences in rates of death from breast cancer, and found that treatments really varied by race. And when we got to some of the underlying reasons as to why they varied for a third of the time because the patients were told and didn't refuse, just didn't want it, mostly for risk benefit. A third of the time, the docs just didn't offer it because they didn't think it would benefit the patient. And a third of the time, they offered it, patients didn't refuse, and it never happened. And so in terms of thinking about, that last episode actually happened much more among Black and Hispanic women with breast cancer than among white women. And so there was a quick, easy sort of technologic fix to that, which I'm happy to go into if you want. But social determinants have played out through it, basically whether people get screened for cancer, whether they can be connected once they have an abnormal screen, whether insurance will cover it or not. Then once that happens, whether or not they can be diagnosed and subsequently treated. Across all those phases, people drop out because of issues of access and payment and transportation, as well as other factors and barriers that impact, such as childcare and elder care, but also a lot having to do with perspectives and how cultural norms impact how people think about illness and how people think about diagnoses and treatments and what they're willing to undergo versus not, and the importance of how we talk with patients about different entities. Along the whole spectrum, how people end up interpreting their symptoms, reporting those symptoms, and actually getting to the doc in order to be able to have those symptoms received and have some action follow on that. All of these things are affected by an individual's self-efficacy and access, which includes not just having a place to go and being able to get in touch with them, but being able to pay for it. So, I can give you examples across lots of different projects that we've been doing out in the community across safety net hospitals, if you want me to go into details about that. But it's a broad area that is screaming for change.
Great. Maybe elaboration on the safety net in a little bit, but I am curious to hear what that quick technical fix was you mentioned before.
Yeah, so what we found was that, because the docs were actually ordering these referrals and patients didn't seem to show up, they really were falling through that safety net. And so all we did was we closed the referral loop. And so we would find women who were recently operated for their breast cancer, and we would see whether or not they had the pathologic features that would require either local or systemic treatments. And we would find out whether they had a follow-up visit scheduled with that either radiation or medical oncologist. And we would have the date of that visit. We would then call to see whether and when we could on the EMR, because this was years ago, we would check to see if the patient showed up. If they had, great. And if they hadn't, we would reach out to the doc's office to say, what happened with this patient? Because we knew if the doc would reach out to the patient to follow up and make sure they connected, it was much more likely to happen than if anybody else did that. So simply closing that referral loop was actually quite potent and eliminated disparities in treatment.
Great, thank you very much. Dr. Velaswamy, the same question, but from your perspective.
Yeah, I think Dr. Bikel is a leader in this field, so I think kind of the breadth of her research really, gave you a comprehensive view of the importance of social determinants. So maybe what I can, from my perspective as a lung cancer doctor, I can kind of, echo and highlight what's some of the issues that she mentioned, how it impacts the patients that I treat. I think social determinants of health, have a global impact, on patients in general. When you think about health, safe housing, education, job opportunities, which of course impact the income patients have. And this, economic stability is important for transportation, the ability to miss work, to come to doctor's appointments, childcare. I was thinking about this, and I had a patient a couple of months ago, and he was a grandfather that lived really close by, and he came to his appointment with me, but he was very sick, and we needed to send him to the emergency room. And he adamantly refused and said he's not able to because he was watching his grandkids, and his neighbors agreed to watch them for 1 hour while he came to our appointment. And he said, I'll go tomorrow when someone else can watch the kids. And he was very, very sick, and it was really sad and kind of scary moment. But these are real issues. And then additionally, when it comes to the disease itself, I think a lot of preventative treatments and screenings are unfortunately underutilized in racial and ethnic minorities, and this ends up leading to much more advanced disease that we have to treat with poor outcomes. And then, as Dr. Bikel was talking about, sometimes it's provider, as far as treatment decisions, and you always want this to be kind of a shared decision between provider and patient, but it doesn't, work out that way a lot of times. And, there's provider factors, there's patient factors, and there's a lot of, even, from the patient perspective, there's been a lot of research that shows that there's, medical mistrust, and patients don't seek out medical care, for concern of discrimination. And these are real issues that impact outcomes and the health of our patients.
Great, thank you very much. And Dr. Khalil, your thoughts on how social determinants of health impact your work. And I will add a addendum to your question, specifically because your work with minimally invasive surgery and robotics is kind of like the highest end of clinical technology when we think about this kind of work. Does that help mitigate the effects of social determinants of health for you, or is it something that even when all of this technology is present, these still persist?
I think so. I think thank you very much for a great question, and I'm so honored to be with my co-panelists who've really built a good foundation on some of the underlying challenges with social determinants of health. Specifically for minimally invasive GYN surgery, it's helped alleviate many of the different limitations that present as barriers for social determinants of health, such as job insecurity, making sure that they're able to get back to work in a sooner fashion. So it's really helped from that perspective, patients who don't have job protections or have childcare issues and their ability to become more functional in a faster fashion. So I used to work in a safety net hospital after fellowship my first 5 years out, and it really helped me experience a lot of the different challenges that I encountered with some of my global health work as well, where, it's really true that health is where we live, work, and play. So you can do amazing surgery and have all these things, but in some of the patients who had housing insecurity and things of that sort, they'd have to go back home to a shelter or something. And if there could be areas for improvement for bridging those delays in bureaucratic transitions and gaps in that resource arena, that would be a great opportunity, for a patient to have a stable environment to recover in those first 30 days after, in a way that technology, I think, can help. I've done a lot of research initially in research ethics and what patients understand and how they interpret different things. So a lot of my research work has really been more patient-centered outcomes and qualitative research methods for what they hear versus what we say, and how to deliver it in a way that will be appreciated by them and understood in a good way. I found that technology has been one of those things where we've had small wins, but other limitations with not just health literacy, but literacy and cultural norms about surgery and what to expect in the recovery period and things of that sort. So it's really, really important to engage your patient population and your community. From the clinical aspect, it's a lot of the social determinants of health that lead to certain conditions like precancerous conditions in the uterus that can lead to endometrial cancer, for example, that minimally invasive surgery has been helpful for in reducing wound infections, recovery, and different elements of care. But the impacts of trying to do health education, I used to have to use resources like a patient navigator, using reading material and different resources have not been as helpful. We've done trials with tablets and gotten certain kinds of funding to try to engage it, but it's really more of a community approach to it that has really engaged the patient population for a better recovery. Currently, we have something called the Enhanced Recovery Pathway, which is a great national metric, but it really brings up the question of, do certain quality metrics drive disparities in care? And meaning that while we have these resources for many patients nationally, sometimes you need additional resources to bring this enhanced recovery process to different populations that have social determinants of health that impact this care. So translation services have been great, and I think a really strong translation service has always been a helpful bridge in these gaps in community and cultural engagement. Patient navigators with flexible scheduling. We used to do just flexible scheduling, so moms and their children could come in anytime they needed to. And really, if there is a way that technology can help optimize resources for gap closure with different things that enhance social determinants of health, where patients go home to recover, so that the hospital is not the best place for them because they feel that's where it's safest, or they're insecure about caring for themselves. Those are things where I'm really hopeful from those aspects in care. I think bringing different kinds of surgical specialties requires also investment into different kinds of hospitals in various areas, and not just in academic centers. And that's another area that I'm hopeful that this new attention with social determinants of health will bring as well. So I think that's all I have to add, but I welcome any questions. Thank you.
Great, thank you very much. And I want to kind of build off of that, kick it back to the other panelists, starting with Dr. Bakel. But Dr. Khalil, you mentioned how technology has, to some extent, helped level the playing field in terms of recovery time and access and ability to set aside time for recovery. And so that's an instance where technology has helped. But then you mentioned other places where it's still kind of lacking in terms of serving a diverse patient population. So what I'm curious to hear from you, Dr. Bickel, is what's an example or some examples where technology has like very clearly improved our ability to care for a diverse patient population, but where is it still lacking?
That's a great question. So there are so COVID actually has taught us a fair amount, even just within the Mount Sinai Health System, in terms of telehealth, of being able to access video visits, and what some of the challenges have been and how we've addressed them to really try to improve access for vulnerable populations who may not have the same kind of technologic savvy. And so there was a huge effort that took place to try to teach patients. I see patients at IMA, and to be able to enable patients to connect to a video visit was a real push, and especially in oncology, this happened as well, to enable patients to be able to connect electronically. So that has gotten better. It hasn't leveled the playing field yet. There's still a fair amount of work to do for that. There was a wonderful project that came out of Memorial where they were looking at patient-reported symptoms and this was for cancer patients, with the idea that patients can report their symptoms when they have them to electronically to a nurse in general, so that they could react in quick time, in real time, to get back to patients, essentially to nip things in the bud when they could, so that patients don't end up coming in septic and in much worse shape. And the process of doing that actually markedly improved patient outcomes, both in terms of hospitalizations and mortality. But the thing that was fascinating about it was that they did this across the board, and the folks who really seemed to have a bit more of an improvement in their outcomes were the group that were originally technologically less savvy, because as they learned to do this and improve their access, they actually got better outcomes. So I think there are ways that we as healthcare delivery systems can build in to educate and enable patients across the board to be able to monitor and respond and have ways of checking in. There are lots of different projects going on that are using home-based monitoring for blood pressure, for sugar, for symptoms, for just for heart rhythms, et cetera, that have just exploded and made access and the potential response time so much better. But with all of those, you do have to make sure that you know that patients understand how to use the technology and that you have someone on the receiving end that's actually responding.
Great.
Yeah, expanding on that, as far as the remote monitoring. So we have trials now that are using these remote monitoring devices. And when the first version of these devices were like huge kind of devices that weren't practical, but the technology's gotten better, and they're the size of kind of large coins, and they just fit on the shoulder, and they can, as was saying, they can measure vital signs in real time, and patient steps and all kinds of longitudinal data to be able to inform providers with minimal actually participation from that level, except for wearing it.
Yeah.
But the idea here is that it can really raise those red flags or sound those alarm bells for providers to act earlier as far as treatment, toxicities and so on, to improve things. And I think that's it's a super interesting idea, in that we have that ongoing as a large cancer center effort at Mount Sinai, and there's several trials as well that are going on. So I think there's opportunity there.
Great, thank you. And Daniel, you're not seeing patients yet as a healthcare provider, but As you mentioned before, you are seeing patients in a bunch of other contexts. And so, in the ways that you are interacting with the patient population, how is technology helping solve some of the problems and bottlenecks you see, and where is it falling short? And I will add on to you, what are ways that when you become a provider, once you advance in your career, what are some technologies that you're interested in learning more about?
Yeah, it's a great question. I think this might be a little bit of a non-conventional answer given my background, but I think one piece of technology that has been both very exciting but also has its drawbacks is sort of the use of these large anonymized omics database or like genomics and sort of like methylation data style databases that have been published recently. And they're really amazing. I think just because we've been able to access like genetic level data for patients on sort of like a pan cancer spectrum, which enables these really amazing sort of studies on what are the genetic drivers of tumors. But I think that these databases do suffer from the exclusion of patients and sort of who are maybe less financially able or less sort of like health literate or have different risk factors than patients who are sort of like health literate and manage to get access and sort of enroll in these studies. So, I mean, this is one thing that I see now just through the consenting process at Mount Sinai that, like I mentioned before, patients who aren't English speaking get excluded. And so, you predominantly have patients who are English speaking who are sort of included in our genetic studies. And these are the types of studies that do get uploaded to these large online repositories. And so it definitely biases the patient cohort that you do have access to. But that being said, I find it also very sort of like an encouraging thing because unlike cohort databases that were used in studies past, these are sort of living, breathing online databases. So you can like update them as you go. And so as people get the sort of like the financial means necessary to expand consenting and to expand the outreach and sort of shift priorities from sort of like a minimal viable product to like a more health equitable product, these databases can actually like have a massive impact. So I think that to your point, the use of online databases is something, and like online omics availability is something that I am really sort of hopeful for in terms of like improving immunotherapy specifically for patients. And as somebody who's has like a future role, I think that it's hard, especially when you're put in this situation of having financial constraints towards research. But I think that's something I want to be able to do is try to sort of have health and sort of like research be implemented in a way that's sort of agnostic of ability to pay for that research from like the patient's perspective, if that makes sense.
Yeah, great. Thank you very much.
Can I just add something to that?
Absolutely.
Because one of the key things in terms of actual social justice has to do with who ends up being in these databases, who ends up joining into clinical trials. The only ways that we're going to be able to tell what works for everyone is to actually have everyone contribute to these different databases and trials so that the results actually apply to everyone. And that's not what exists currently. Absolutely not. And the proportion of BIPOC populations that contribute, that are included in these different databases, that are included in clinical trials, is just so much lower than they actually represent in the population, let alone in the groups of different diseases, because in general, BIPOC populations have higher rates of morbidity and mortality, that they simply are not included in the numbers that they should be. And it is up to us to really figure out ways to change that, because the only way that we're really going to change the current treatments and approaches that we have is to ensure that we have that kind of inclusion and recruitment from the very outset.
Yeah, I think the more recent efforts have been a little more thoughtful on this, as far as like, especially kind of NCI backed, genomic databases with CPTech is a pretty diverse population. So definitely, I think there's been some improvement, but plenty of room ahead. But I think you're absolutely right about clinical trial accruals. Mount Sinai, interestingly, does a pretty good job, probably because of a lot of efforts internally, but also our patient population. But overall, I think it's a huge issue, and it's what you're doing is exactly what Nina's saying is that you're extrapolating, right? You're saying that whatever the outcomes in this very set clinical trial population is applicable to every single patient, with this disease, and that's not true, right? And so, and that's been shown several times. I think technology is going to help things because as technology gets better, everything gets cheaper. And as things get cheaper, I think then we've gone from, as a standard clinical, assay, we've gone from testing 50 cancer genes to now testing 161. And soon enough, we're going to test the whole genome, and that's pure and simple because things have gotten cheaper.
I want to add to this as well. I mean, it's something that definitely interests me as well. But I think, the exclusion of certain populations isn't sometimes because they're not offered certain trials or opportunities, but sometimes there's certain barriers that it takes to travel outside of their community. And then there's internal barriers from research ethics committees, where I've played an active role on for many years at this institution and at my prior institution as well, where there is concern about, offering financial resources for transportation and other things like that may influence the participants' willingness, that they feel coerced to join. So that's where there's like a lot of different areas in ethics where we can really make a little bit more progress. And I think if I didn't work in an area that was underserved with exceedingly really rare kinds of cancer, and when you'd refer them in for these amazing trials and they would get accepted, but many just couldn't travel being so ill and didn't have the support to family engagement and other factors that would help facilitate this process. So I think it's an area where we can definitely improve upon. I'm not really sure how technology can help, but I would love to see if it could.
Great. Thank you all very much. And I would just quickly, before I get to the next question, also remind all of the viewers that you can enter in questions of your own. We will see it here in the chat, and we'll be able to ask those questions from the panelists as well. So feel free to ask away, both Thrive Fellows and non-Thrive Fellows. We want other people to be engaged in the discussion as well. But I'm going to do a couple of more specific questions. And so this one is specifically for Raj. You mentioned advances in monitoring and remote patient monitoring. But what is something that maybe isn't being monitored yet that you wish was monitored?
That's a good question, and I think we're ultimately we're going to get a lot of data, and in these trials or these this use of technologies, the actual implementation of it's not, it has not exactly been figured out because there are different issues at the patient level, about using them. And how the studies are they're sometimes they're not thought out. This one study with this remote monitoring device, it has patients wearing them for a whole year, right? It's just not practical, and especially with the toxicities we're looking for, probably are going to happen more up front, and there's probably a smarter way to do it so that patients are more open to it. And because I think when you describe it to them, they see the benefit of it. But at the end of the day, I mean, they have to live their lives. And so, but ultimately, from the provider side, we're going to get so much data, and what does it all mean, and kind of where do you set your your red flags and alarm bells and so on, and how do you incorporate it, with other patient-reported outcomes, like that other study, and other important data from the EMR and so on. And so I think this is, kind of these bigger questions on, the idea is very, very sound and very good. And I think it's going to be able to help outcomes, and it's been shown to, but I think there's a lot of optimization going forward.
Great, thank you. And I'd like to, for Dr. Patel, I'd like to flip the question around. Instead of asking, what is more information we can extract from the patient population, what maybe is more information we can extract from the provider population and from clinicians who are seeing and treating patients?
I think we have a huge missed opportunity, actually, in terms of our data systems, because we do collect an amazing amount of information on patients. The challenge is, what are we really doing with it, and how are we optimizing it to optimize patient health and well-being? And I don't think we've gotten anywhere near the sweet spot for that. So, for example, in one of the projects that we did where we were looking at men with prostate cancer, and we were looking at not just whether they had gotten guideline concordant treatment, but understanding kind of why. And we were looking at men with locally advanced prostate cancer where actually treatments can make a difference in terms of survival. And one of the things that we found, excuse me, was one of the men that we were talking with in our focus group actually had been originally diagnosed with what was at that time locally advanced prostate cancer, but really by the time somebody noticed that his PSA was high and had been high for quite a long time and nobody had done anything about it, that he was already metastatic. And there's no reason for something like that to happen when you have an EMR that actually is tracking on these very regular time frames of watching his PSA go up and up and up and up. So, I think for us, what we should really be thinking about are, what are some of the key pieces of data that are critical, that we collect anyway, that are critical to be following to ensure that we're doing the best for our patients.
Great, thank you very much. The chat is open to viewers, but Dr. Khalil, I do want to ask you a question specific to some of your work. You've worked in a bunch of different healthcare environments in terms of resource availability, and currently you're doing some very high technology stuff here at Sinai. But what are some opportunities that you see to maybe help bring technology that is currently only available in very high resource areas to lower resource areas? Is that just decreasing of cost, or is that new ways to kind of build some of these surgical systems?
Yeah, I have a wish list for this, and that would probably be, there's a lot of different great features on the robotic platform, but for laparoscopic platform, which offers a more cost-effective solution, even though robotics really has tried to change the landscape of this, and I anticipate that change in the next few years. But I think fibroids disproportionately affect women, and it's one of those things where it's not well understood. There's a lot that we can do to try to enhance minimally invasive surgery for this. So perhaps intraoperative analytics on volume estimation may be one thing for laparoscopic surgery. That would be one thing. Other things are advances in intraoperative imaging. So some limitations to using laparoscopic surgery for fibroids or minimally invasive surgery is the lack of haptics and limitation in feeling other fibroids that's within the uterine myometrium. So it's one of those things where that's a role where technology can really try to advance intraoperative imaging and just provide more information, so that we can try to take the numbers from laparotomy to minimally invasive surgery more so. So that's definitely an area where I can see improvement. And then lastly, in the recovery phase, maybe just greater monitoring or feedback to patients for optimal mobilization And at the end of the day, I'm going to echo what Dr. Bickel just mentioned, which is identifying relevant metrics. And that's by trying to engage the relevant stakeholders, which are the frontline clinicians in these aspects and the teams that care for them. Thank you.
Great. Thank you very much. We've got a question in the chat specifically for Daniel from Ian. And so Ian wants to know, could you speak about some of the work being done at the Diversity Innovation Hub, and how can you get involved as a trainee at Mount Sinai?
Yeah, definitely. Can you guys hear me? I switched my mic. I don't know if it works now.
Yep, we hear you.
Awesome, perfect. Yeah, so my work specifically with DIH revolved around the Spotlight series. So essentially, the idea around the Spotlight series is we would contact people who were sort of influential individuals in the field, working on issues that are sort of central to diversity and innovation. Specifically, this includes people like Adamika Arthur, who is the head of health tech for Medicaid, who sort of is a sort of California-based program, really seeking to connect individuals who are in sort of a startup role with people who are influential in the Medicaid area, sort of marrying the spaces of more like public health decisions as well as technology and innovation. And then another individual I worked with was a physician named Dr. Christina Jenkins, who's actually has had a crazy number of experiences, was a physician for a while, and then made the jump into venture capital. And now she specifically is the leader of a venture capital fund who works to fund individuals who are sort of female and underrepresented minorities, specifically to get more backing from an institutional and financial perspective towards those businesses. So the series that we did was really trying to highlight their efforts to students and trainees at Mount Sinai to show people that you really can marry this like non-traditional path while you're in medical school, as well as like the master's programs and the PhD programs. So that's my experience at DIH. If you're interested in getting involved, there's a DIH website, and we have sort of quarterly programs that we put on. I can link that here if you'd like. I can just sort of shoot the website over, and you can reach out to us, and we can sort of get you hooked up with the programming that we have.
Fantastic. Thank you very much for the information on that. We're actually getting close to the end of this panel event, so in the interest of time, I want to get to kind of one big question that I want to make sure everybody gets the chance to answer, and that is, what's one recent healthcare innovation? It can be an app, a device, a new methodology, any kind of innovation that excites you. So Dr. Bickel, if you want to take the first pass at this broad question.
So I think that the whole AI combined with obviously machine learning is incredibly exciting, and being able to combine what people have both genotypically and phenotypically, and how they respond to different treatments and what their outcomes are, is incredibly exciting, potent, and can really change the way we do things, I think.
Great. Thank you very much. Danny, I'll kick it over to you. What's one healthcare innovation that excites you?
I think it's going to be a really boring answer. It's not necessarily AI. I am really excited about the premise of telehealth. I think specifically when you're thinking about bladder cancer, people have a lot of questions. It's really scary going through these major surgeries. After bladder cancer surgery, you oftentimes have a stoma where the urine comes out. So it's really life-altering in a lot of ways. And I think being able to like set up appointments in a way that's a little like lower cost to both the patient, but as well as the physician, makes healthcare more accessible in like a way that's very simple, but also like really core to making somebody feel more comfortable with a life-altering surgery. So I think I'm really excited to see how like telehealth continues to improve, both from like a logistical standpoint, but also to see how it really like impacts patients in a longitudinal perspective when you're thinking about like years and years and years of telehealth, and how like those touch points can like be easier and also change somebody's care in the long term.
Great, thank you very much. Dr. Khalil, same question. what's one healthcare innovation that excites you? Oops.
Well, I think, I don't know if it's rolled out fully, but I love the idea of telepresence and augmented reality for intraoperative presence, where you can have another surgeon who helps like draw different diagrams and help you out with different procedures. So that's something that I'm really, really excited about. And I just wish it was just a little bit more accessible.
Great. Thank you very much. And last but not least, Dr. Velaswamy, what's one healthcare innovation that excites you?
Yeah, so we have a grant, and the project just got kicked off, where we're using natural language processing to go through all the unstructured data of that we all put in our clinic notes to try to derive meaningful information from there to create risk classifiers for outcomes. I think that's pretty cool, but I'm enormously biased.
Great. Thank you very much. We are at time, and I want to respect everybody's time here and watching. In classic excellent panel style, we went through less than half of the questions I had prepared for everyone. So thank you all for a fantastic discussion. And thank you all very much for taking some time out of your day to join us and participate in this event. And thank you to everybody watching for your questions and for your attention. Hopefully this gets a lot of our Thrive Fellows and the wider innovation community at Mount Sinai thinking about all of the different opportunities there are to get involved in healthcare innovation. So thank you all very much, and I will kick it off from here. Thank you also to Jimmy, who has been operating in the background, making this whole presentation look so wonderful and cool. So thank you again, everybody, and I hope everybody has a wonderful rest of their day.
Thank